Good afternoon, and welcome to the fourth webinar in the Poplar Network Lunch and Learn series, EDIIA and Research. As most of you know by now, EDIIA stands for Equity, Diversity, Inclusion, Indigeneity, and Accessibility. For advancement and quality improvement in primary healthcare to be done equitably, research and practice-based learning must be grounded in EDIIA principles. The Poplar Network is Ontario's primary care learning and research network. We are committed to advancing equitable primary healthcare delivery and health outcomes for everyone in Ontario. We've launched this webinar series to support that vision by building capacity for EDIIA-oriented research in primary care. The Alliance for Healthier Communities is pleased to be hosting these webinars on Poplar's behalf. For those of you who are unfamiliar with us, the Alliance is a membership association for community-based primary healthcare organizations in Ontario. All of our members belong to the EPIC Practice-Based Learning Network, which is one of 7 such networks that together make up Poplar. Poplar, in turn, is a member of the Canadian Primary Care Sentinel and Surveillance Network, or CIPSEN, which includes primary care learning and research networks from across the country. We're glad you could all join us today for the 4th webinar in this series, which is about building your team's capacity to use data to advance EDIIA. Our guest today is Dr. Andrew Pinto from Upstream Labs. I'll introduce Dr. Pinto properly in a minute, but first we'll cover some housekeeping, and then we'll start things off in a good way by acknowledging the original stewards of the land we're using today. This will be quick because most of you are probably extremely familiar with Zoom by now. This webinar is being recorded, and Marissa will send out a link to the recording along with the slide deck later this week, so please watch your email for that. There will be a Q&A and discussion period at the end of this webinar, so please submit your questions in the Q&A panel. Feel free to start typing those at any time as soon as you think of them, and we'll ask them on your behalf and do our best to group them up thematically. If you prefer, you can ask your question out loud. Please use the raise hand function to do that, and we will unmute you when we call on you. You can find the raise hand function by clicking on the reactions button at the bottom right of your screen. Please remember to mute yourself afterwards so we can keep background noise to a minimum. If you run into technical problems and need help, please use the chat function to connect with me or Marissa or Jen. Now, please pause with me as we acknowledge the original stewards of the land where we are virtually gathering today. We recognize that the work of the Alliance for Healthier Communities, our members, and the Poplar Network takes place across what is now called Ontario, on traditional territories of Indigenous people. They have lived here since time immemorial and have deep connections to these lands. We further acknowledge that Ontario is covered by 46 treaties, agreements, and land purchases, as well as unceded territories. We're grateful for the opportunity to live, meet, and work on this territory. Ontario continues to be home to vibrant and diverse Indigenous communities who have distinct and specific histories, needs, and assets, as well as constitutionally protected and treaty rights. We honor this diversity and respect the knowledge, leadership, and governance frameworks within Indigenous communities. In recognition of this, we commit to building allyship relationships with First Nation, Inuit, and Métis peoples in order to enhance our knowledge and appreciation of the many histories and voices within Ontario. We also commit to sharing and upholding our responsibilities to all who now live on these lands, to the land itself, and to the resources that make our lives possible. My name is Catherine, and I am a settler here. I live and work on the traditional territories of the Anishinaabe, Wendat, and Mississauga peoples in what is now called Toronto. And now I'll introduce our speaker. Dr. Andrew Pinto is the founder and director of Upstream Lab, a research team focused on tackling social determinants, population health management, and using data to enable proactive care. Andrew also holds the CIHR Applied Public Health Chair in Upstream Prevention. He's a public health and preventive medicine specialist and family physician at St. Michael's Hospital in downtown Toronto, and he's an associate professor at the University of Toronto. He is the Associate Director for Clinical Research at the U of T Practice-Based Research Network, or Utopian, which is one of Poplar's member networks. And he is the lead for artificial intelligence in a new initiative at the Department of Family and Community Medicine on how new technologies will change healthcare. And with that, I will turn you over to Andrew. Andrew, the floor is yours.
Thank you so much for the invitation to present today, and I really look forward to the chance to engage with everybody who's attending in this discussion. I want to also begin by acknowledging that I'm in Toronto, which is the traditional land of the Huron-Wendat, the Seneca, and most recently the Mississaugas of the Credit. And I am deeply grateful for this opportunity, particularly as a child of immigrants who have come here, but also when I do a land acknowledgement, I just want to provide something specific that ties into what I'm discussing. And I want to really promote this fantastic book on Indigenous data, sovereignty, and policy, which has a chapter on Canada by colleague Robin Rowe and others. It's really a helpful resource as we're starting to think about these ideas about EDIIA and data. I also want to just disclose I don't receive any funding from for-profit entities or commercial organizations, but have been very fortunate to receive salary support and funding from CIHR and other sources. So today I'm going to talk a little bit about the three kind of areas. One is talking a bit about the Upstream Lab and our journey around data, around these ideas. I'm going to talk about lessons from the COVID-19 pandemic as an example of both what can go wrong and also what can really be positive when we think about data, its collection and use. And then I'm going to end on some recommendations, which I put together into a commentary around really kind of asking the question, can EDIIA be transformative? And then we'll have lots of time for questions. So just to get us started, the lab and our journey. So some of you may have visited our website or be on our newsletter where we share what we're doing, but essentially the lab is definitely beyond me. It's this really fantastic community of people, staff and graduate students, many different collaborators, patient partners and community members who are all engaged in this idea of ultimately, can we improve health through going upstream of the downstream issues we see in our clinics and hospitals. And we group our work into these three areas, partly because thinking about the social determinants can be really overwhelming. So this helps us also kind of categorize what we're doing. We do work on integrating health and social care, such as addressing the needs of individuals. We use data science for establishing learning health systems. So part of what I'm going to talk about today is data on sociodemographics and social needs. But we also do work on artificial intelligence and also really how do we construct health systems, including through upstream education. We do work on population health management, shifting health organizations to think at a population level and think about accountability. And we also do things that are maybe even further outside that area, thinking about policy change, which ultimately would shape social factors. So how do we engage our patients and communities that we all belong to in democracy? How do we build policy coalitions that create change? And what could be done at maybe a community or local or neighborhood level as well? One of the key kind of things we've put together is this framework, because when we first started about 6 years ago now, we know that even the idea of going upstream and tackling social factors was really overwhelming for many, many hardworking people in the healthcare system, most of whom are just struggling to kind of keep their heads above water by tackling, things that are coming into clinics and hospitals. So we said, let's provide a framework that could be helpful for health organizations to go upstream. And just to walk people through this, it begins with data that we are generating through our activities, but also broader health service data about how people are using the rest of the system. community data on the communities that people are embedded in, but also routinely collected sociodemographic data. Now, I'll say at the outset that many members of the Alliance for Healthier Communities have been doing this type of data collection for many, many years, even decades. But this idea of collecting this, rich social data is fairly new to other parts of the health system. Now, what can this data be used for? It could be used to create change in how we practice. As a family physician, this could actually influence the type of prescriptions I make, or referrals or connections to community services. But it can also be useful at a practice level, thinking about where are there hotspots and in the people who I'm responsible for. And in step 3, it can be used to actually change things at an organizational level, change business practices, develop new programs, endorse advocacy campaigns as an organization. This information can also be used to inform system evolution. For example, changing how we train health providers. It can lead to new relationships in other sectors like housing, education, the financial sector, employers, and others. And it can also shift the discourse that we are all part of from downstream to more upstream thinking. So if you think about how many articles we've all seen in the media over just the last few months about the crisis in our emergency departments and being able to access care, long wait times, could we shift the discourse to something that's more thinking about the upstream factors that are influencing this? And finally, this can actually be used as a foundation for policy change as well. So just to dig in a bit deeper around the social data, we have kind of come up with this term of patient-reported and inferred social measures. Inferred meaning that it could be inferred from people's postal code or potentially from other parts of their health record. Now, the story of this begins almost 10 years ago, where leaders at the Toronto Central LIN, or Local Health Integration Network, really said, let's start to bring together people who are doing this work. And again, recognizing that community health centers had been collecting this data for many years. So building on that experience, what would it look like if we collected this in hospitals in a standard way? So a group of folks, mostly in Toronto hospitals, said, let's test these types of questions and routinely try to collect this from each of our patients, these types of areas. Well, I was part of it at the St. Mike's Family Health Team, and we found that people were quite open to answering most of these questions. You can see income had the highest rate of preferred not to answer, but many of the questions people were quite open to answering and providing information when they understood that it was something that's going to be kept secure and similar to other personal health information that they divulge. And so what could this start to be used? This is just a few examples of how it began to be used for quality improvement initiatives, and also to understand patterns. For example, showing that certain groups, certain ethnic or cultural groups, were less likely to participate in cancer screening, and being able to then that lead to interventions and create change. And so we start to see really, and this is with my colleague Dr. Tara Kieran, that we could think about how this could be useful at the point of care, at the organizational level, and at the health system level. This led us to, in 2018, to apply and get a large grant to do some work across the country, what we call the SPARK study. And you can find out more about this on our website project page. This was with colleagues in Saskatchewan, Manitoba, here in Ontario, and Nova Scotia and Newfoundland. And together we all said, we would really want to have a standard set of questions that we could use in primary healthcare and potentially other parts of the health system. We also were really interested in this project and how the real implementation issues, but also could we intervene on these social needs? So along this way, we've published a number of different papers about the collection and how people react to being asked these questions and the use of this type of data. And what we've learned so far, and it's still ongoing as we're just finalizing kind of a set of questions that we're calling the Spark tool, and also embarking on more validation of these questions and implementation. These are kind of our top 10 kind of lessons. One is that leadership and staff really have to be committed. They have to fully understand why this information is being collected, what could it be used for. Indigenous data governance and sovereignty is so essential. And that's something that I think has not always been held up, and it's really taken Indigenous patient partners who are part of our team and colleagues in Indigenous health research to point this out, to now the point being where this information shouldn't be collected unless there is the appropriate data governance and sovereignty principles in place. Community engagement for non-Indigenous communities is also really important, and I'll talk a bit about the EDIIA framework. The commitment to transparency is so essential, a commitment to taking action. And I'll come back to this point when we talk about EDIIA more broadly. The idea of continuous data quality is essential, staff training, and also quality assurance around staff training, appropriate communication to patients, that there's a complaint process if there is discrimination, and protection of this data and privacy. And I always like to point out that these key issues are not only things that arise from our work, but they've been raised by many people before me. Just as some examples of this, there's a set of fantastic books that have been come out that, you know, by many different colleagues like Ruha Benjamin and many others that really point to the concerns and potential misuse of data on social data, particularly data on things like race, but also really for others that could actually have it misused. So I want you to keep this in mind as we start to talk about data as part of EDIIA processes. And this is just another example of other colleagues, in this case, Dr. Ani Norum, Dr. Kate Mulligan, and Dr. Marcia Anderson, who all talked about the collection and use of data on race during the COVID pandemic, and potential concerns as well that would come up. And this is, of course, the ownership, control, access, and possession principles from the First Nation Information Governance Center. And then this is the EDIIA framework. So this was something new that arose during the pandemic from an Ontario group called the Black Health Equity Working Group. And I think it's a really important and novel contribution to this idea of, for non-Indigenous communities, what would it look like to engage them in governance of this data and engagement with it? And so it goes through these principles of engagement in a genuine, open way, governance so that communities are actually involved in making decisions about how this data is collected, analyzed, and used. Access to the data, which is one of the most difficult things to accomplish when this information is collected as personal health information. How do you enable access to it by different communities, whether it's the Black community, South Asian community, East Asian community, or others? And then also protection of this data to ensure that it is not collected and then sold to for-profit entities, or it's not used to actually cause harm, such as by increasing surveillance on certain communities. So that's kind of an ongoing journey that we still have much to learn from, but around collection use of data in healthcare settings. So I'm going to turn to now lessons about this type of data collection during COVID. So we knew really early on in the pandemic that the social determinants of health would be really important and play a role in who got sick and who died. And we knew this because in previous pandemics and previous infectious disease outbreaks, and essentially almost all aspects of human health, social determinants play a key role. We did a rapid review of the social determinants of COVID, and in just the first kind of 4 to 6 months of the pandemic, there was numerous reports that we could identify that pointed to the social determinants of COVID, that things like race and ethnicity, income and occupation, were really key in who was getting COVID and who was dying from it. Now, there was a big movement in Ontario to ask and to suggest to public health professionals that they collect data on things like race and other social determinants. And unfortunately, I think some of the leaders at the time, expressed really an ignorance of both historic pandemics and also what the contemporary data was showing already as early as March of 2020. And unfortunately, statements like this, that regardless of race or ethnic background, everybody is equally important to us. And, the issue is not that any individual or any organization is going to purposely treat people differently. It's about systemic racism and being able to identify and then tackle that. So with others, we were part of, calling for the collection of data on race, but also to do it in the right way. So we had these 4 recommendations to collect data on race, but also other social factors, to use the same questions across provinces, to have a preface that helps explain that race is not about biological differences, but about systemic differences in how people are treated by organizations and by society, and to really commit to transparency around this. Now, this helped influence the Canadian Institutes for Health Information when they submitted an interim set of guidelines around this. And ultimately, we did see many provinces start to collect this type of information. And here in Ontario, with this community mobilization, the public health officials did move to mandate this type of data being collected in Ontario in a standard way across public health units. Now, there are some downsides where, unfortunately, we saw stigma, discrimination, and lack of intersectional thinking. So you'll see this as a theme that comes up, which is data is certainly not always, it's not neutral, and there can be harms. This is from here in Toronto, where we saw, unfortunately, the South Asian community be blamed for COVID. And, when information on higher rates of COVID were found in the South Asian community, it was, the blame was put on things like getting together for Diwali and other types of things like that. No mention of other social factors of why racialized folks would be more likely to get COVID and die from it. We also saw this in Nova Scotia, and this is colleague Dr. Amisur Dryden, and some of the powerful work that she's done. And she mentions in this article, like she tweeted, up to let's be cautious about this, but unfortunately, there were still examples where certain racialized groups, in this case, Black Nova Scotians, were being stigmatized and whole communities blamed for outbreaks of COVID. Now, in Ontario, the data was collected, and it eventually led to reports being able to show that indeed there was a really disproportionate impact on certain communities. But I think what was much more important, which unfortunately gets a little bit missed, is what this led to. And what was really powerful is that we saw this information being used to justify and argue to policymakers that resources were needed, that real dollars and funding were needed for, in this case, things like community outreach, for specific vaccine clinics that were oriented and led by communities. And I really want to, pay tribute to community health centers that actually did so much of this work, but also that it created the argument to go to places like the City of Toronto and say, we need specific funding to narrow these gaps. This is an example from Hamilton, which said, someone saying it's not just about equity, it's also good public health policy to have these specific clinics, to have this outreach. And what's remarkable is that we actually saw the narrowing of differences and health inequities. So this is in August of 2020, one of the first examples in Canada where we could actually use data on race and demonstrate that, for example, in this case, Black individuals far, more overrepresented in who was getting COVID, South Asian individuals, Southeast Asian, and that white individuals were actually underrepresented in who was getting COVID. So clearly demonstrating that there is systemic racism in who is getting COVID and who is dying from it as well. What was really powerful, though, is to see these gaps narrow over the course of a year, likely related to the enormous outreach efforts that were being made and vaccine uptake that was really led by communities and using the data as a foundation for it. So using that now, in mind around thinking about the experience of collecting data on social determinants, including things like race and ethnicity in healthcare, and then the experience during COVID, let's talk a bit about, can EDIIA actually be transformative? Will these efforts that we're really engaging in actually create change in our health systems, in health research? So this, as I mentioned at the start, this is some thoughts that I put together into a commentary that was in response to one of the Canadian Institutes for Health Research institutes, the Institute for Health Services Policy Research. They had come up with a new strategic plan, and they asked me to provide some thoughts on the EDIIA initiatives within it. So what I think I distilled was kind of 4 recommendations, and I'll just walk through them and then wrap up so we have lots of time for questions. I think the first thing when it comes to EDIIA is starting with taking an honest and clear history of the role that research has played in upholding injustice. And after that acknowledgement and apologies, actually committing to justice and reparations. So this is really, I think, important because so often, including myself, we come into health research without actually an understanding of what has been the history of research in causing harm and upholding injustice. It's only after being a health professional and researcher for many years that I start to be taught and learn about this history. So that I think has to be a starting point of it, is what has been the history of community connections to health research, what has been the history of researchers in terms of things like extraction of data from communities, sometimes things like blood samples and genetic material, and the misuse of that as well. And there's many, stories of this. There's also more contemporary stories of research and healthcare organizations causing harm to different communities and communities experiencing racism within those organizations. And I think this last part is particularly important, is actually not just acknowledging and making apologies, but actually a commitment to justice and reparations. And what would that look like for health research? For example, in our own network of Poplar, what would it look like to say that we are committing to using our resources to achieving justice and reparations? How does this relate to thinking about where we're putting our resources and even things like hiring practices, things like what are we doing to support research led by communities versus led by kind of traditional academics like myself? So something for us to think about. Another kind of really important point about this is let's really always remember that EDIIA is actually a response to mass movements. This did not come out of reflection and thoughtful kind of decisions within the academic space. This movement that we're in right now, and even why we're hosting, this webinar series now in 2022, is in response to these mass movements, whether it's Black Lives Matter, the Black Health Alliance, which has done amazing work for many, many years around this. We are responding to a movement that has been galvanized by things like the murder of George Floyd and the murder of many others, to say that there needs to create change. And here in Canada and elsewhere, also in response to mass movements by Indigenous communities to finally, seek justice and also to call attention to things like systemic racism in the healthcare system. So with that, it charges us to think about what is our relationship to these movements. Can we build relationships despite the harm that's happened? And how do we make sure that these movements are actually informing what we do and the course of our research? Secondly, and this is maybe more straightforward and probably something that many people will agree with, is we have to stop EDIIA as performative. We really should not have our organizations, ourselves, just make statements without any actions or timelines or changes in the distribution of money, power, and resources. We should really say anytime a statement or letter comes out, we should be asking, is this what is actually going to be done to create change? And changes that are specifically measured in things like dollars and resources and who has power and positions of power as well. Now, a lot of this may seem overwhelming, but part of the discussion I hope we have is how we can be creating change and decision-making that leads to change in how we use our resources. A third kind of recommendation is that data collection alone must never be the end goal of EDIIA. I know that this is often a starting point, and much of what I presented was about data collection, but it can never be the end goal of it. If it does get collected, so for example, in research, we often are reporting on things like what is the identified race and ethnicity or gender identity of people applying for grants and eventually getting awarded grants, or who is in leadership positions. And for example, I've been involved with research led by my colleague Nav Prasad on looking at things like guideline panels and who makes up guideline panels and what's the racial and gender composition. So that is important to do that, but it can never be the end goal. It has to be about being transparent and actually putting the data and numbers in the hands of individuals and communities who are working for change, so that they have it as a foundation for what they're pushing for. And finally, we must really ground our efforts in praxis and parts of movements that are about creating change. And we should acknowledge that EDIIA efforts continue to be part of a response that is about maintaining the status quo. And it takes a lot of, I think, self-reflection and willingness to be open to change for us to acknowledge that. And when I mean praxis, it's a term, from Paulo Freire, who famously was an educator, wrote Pedagogy of the Oppressed, who talked about it as combining, reflection and action that creates change. Now, in research and in academic spaces and in healthcare organizations, often we're reflecting and studying an issue, but not necessarily involved with creating change in it. So trying to change that. As just some examples to make this kind of more clear, as part of our research that we did on the collection of health equity data in healthcare organizations, this is from an interview with a provider who passed on this anecdote of, talking with a colleague at another hospital and saying, what are you doing to address health equity? And someone said, well, we're, administering this health equity survey, period. And it was like, that was the approach to health equity. And that's it. So we're, focused on collecting the data, and that's what we're doing about equity. And we, I think, all collectively would hate to see that what we are doing in terms of incorporating EDIIA into our work, as health researchers, as health providers, would stop at this idea of, well, we're studying the issue. We're collecting the data. And this is from a colleague at University of Toronto, Professor Ronaldo Walcott, who talked a bit about this collection of data during COVID, and saying that, collection of race-based data is a policy decision, but it doesn't guarantee that good policy decisions are going to follow from the data collected. We have to be clear then that collecting data is not an end unto itself. And fundamentally, what's really required is the work that is political work, the need to actually create political change as well. So just to conclude and then open it up for questions and discussion, EDIIA initiatives really have to lead us to see and judge what we are all doing with new eyes. And we have to honestly think about who is setting priorities, who's benefiting, what's the collective impact, and ultimately, is this work emancipatory? Is it leading? I mentioned the term, a redistribution of money, power, and resources, and that's from the wording of the Commission on the Social Determinants of Health, that ultimately what's needed is that kind of redistribution. This is introducing even a further term, which is saying that we need to think about emancipation, and that we need to think about, is the work we're doing resulting in greater freedoms of people and freedoms from systems such as systemic racism that are actually harming people and harming their health. So I'll end there today and just open it for questions. And I think we have, about 20 minutes or so to answer any questions that people have about what I presented, which covered, collection of data, COVID and data collection, and then also this idea of kind of what are we doing when we think about EDIIA approaches within health research. Thanks so much for your time. And again, it's a great privilege to be asked to present.
Thank you so much for that, Andrew. And for everybody in the audience, please enter your questions in the Q&A panel or the chat panel, and we will moderate them. We'll call on you if you'd like to ask your question out loud. You can just use the raise hand function and we will unmute you then. Yes, thank you so much. We do have about 20 minutes.
So I see that we have a question from Barb O'Neill. I'm going to allow you to talk.
Sorry, that was my mistake.
Okay.
Oh, we do have one comment that's come in from Shao. He asks, what is the role of training for implicit bias awareness and reduction as part of this work?
Yeah, thanks for that question. So the question is around, is there a role for implicit bias awareness, training, and reduction? So this is it's a really interesting area, and there's been a fair bit of research, and some of us may have also been actually trained in how implicit bias affects our thinking when it comes to things like hiring or selection of candidates to be admitted. So it turns out that it's definitely a real phenomenon, that there's lots of biases that become part of our decision-making in ways that we don't fully understand. Training, it turns out, I think, plays a very, very minimal role and, in actually creating change. And I think a lot of people in this space are fairly critical of the focus on actually trying to train people to be aware of their biases, and that's maybe the main solution. I think one of the things that worries me about implicit bias training is that it doesn't really result in any changes to money, power, and resources. And it's very easy for organizations to say, well, what we're going to do is try to train people to be aware of their biases, and then that's it, you know. And actually, many of us probably, again, received this training and not really seen much change. One of the things that I think is powerful about data, although it can cause harm, like I mentioned, one of the key things about it, which I always think about, is what Camille Orridge said. She is a well-known, really powerful leader in healthcare and health systems. She was the CEO of the Toronto Central Local Health Integration Network. And she said, and I always think about her words, where she said that data is about accountability. And that is kind of the key thing we should be thinking about, is what is going to hold health organizations, health researchers like me to account. And really, data is very powerful because it allows you to actually judge, are you making a difference? Implicit bias training is almost both from a scientific perspective, is it actually going to change anything? And then also in terms of an accountability perspective, is it going to actually hold organizations to account? It doesn't seem that likely. So we have to think really bigger. And that's where also this point of connecting with communities who are impacted and having them lead and set the priorities is really key.
Thank you. And Jermaine, I'm just allowing you to talk now. Jermaine has a question.
Thank you so much, Catherine, and do let me know if you're hearing me okay.
Yep,
Yeah.
You sound great.
So I guess and I think I have sort of one general question, one more focused, and it jumps off the sort of accountability bit. And I think I'm always really curious about how can policy enshrine tangible accountability? Because I think that's something, you know, around the anxiety of data collection and all of those pieces, and the words of Walcott around, you know, not just collecting data for the sake of data collection, because there's also the dangers of what that data ends up being used for. But how does creating these policies and being really intentional about what will be done with the data, but then also what happens if they aren't doing the things with the data, you know, kind of almost sanction-oriented caveats that hold policymakers and policy agents to account. So that's the really kind of broad question. I'm curious as to what that might look like. And then I'm also really curious about what that looks like for international audiences, you know, immigrant students that oftentimes have difficulties accessing and sort of navigating healthcare, immigrant workers, especially as Canada seeks to ramp up immigration and immigrant workers. But we also know these are populations that oftentimes are missed by the policies and missed by these attempts at accountability. My apologies for the long-windedness of that, but I am curious about your thoughts.
No, it's a fantastic set of questions, and I also appreciate people putting in the questions in the Q&A, and we're starting to see people, you know, engage in this, because I know it can be tough. I think on your first question, which related to how do you hold organizations to account for actually taking action on the data, you know, not just collecting it. It's a really tough problem. I don't have a simple solution because of the way that our hospitals are structured as fairly independent entities with independent boards. They do have a relationship to Ontario Health around what are called accountability agreements for funding. But it's fairly loose, and boards of hospitals and their leadership, their executive teams, have a lot of leeway in what they choose to prioritize or not. And so it's actually really hard. We don't have a system right now in Ontario or anywhere else in Canada that I can think of that actually holds organizations to account, not only for that they should collect this type of information, but actually act on it. And I think there is justifiable, you know, worry from communities and individual patients that if this data gets collected, is anything going to be done? So What we need to do, and we had actually provided a proposal to Ontario Health around this, is we need to establish, likely at the provincial level, tables where if this data gets collected, it actually is presented to those tables and they act to hold organizations to account. And these tables would be made up of a mix of community representatives, but also community members in general who aren't there because of an official role they have. They're just members of that community who self-identify. And these would be fairly large and fairly diverse tables if they, like, people from across the province, from different occupations, from different backgrounds, so that you really got a sense of, okay, so you have, 5 or 6 hospitals and maybe some primary care centers who are collecting data on, say, race. And what are they doing with that data? What is it showing? Where's the accountability? Like that actually creating those tables would be part of it. Of course, it wouldn't be a perfect solution, but it would be, I think, a start. Because right now it's incredibly voluntary. There's no real system that is holding organizations to account. I'll tie your question into one that came in the chat around, can you give us an example of how to use this data was used to actually create change in a hospital setting? And it's one example that comes to mind is the Centers for Addiction and Mental Health, or CAMH. And if you take a look at their plan around addressing systemic racism, it was really built on data that found that, for example, Black individuals who presented to the CAMH Emerge were more likely to be physically restrained and more likely, to have things like longer wait times. And so that data actually was used to inform their strategic plan, and they put in place a number of ideas and initiatives. Now, has it created change? I don't know as yet, because they haven't as yet published, as far as I know, that result, but you can see where that's going. They're one of the few hospitals that I'm aware of that has actually been courageous to publish and share publicly where their gaps are and what they were doing. So that's one example. I think your other question, Jermaine, around students and others who are newcomers is really, really key. That's, I think, bringing an intersectional approach to this, of saying, how does things like people's legal status, their race, their employment and precarious employment all intersect together? One of the things that we need to develop too is a better way to actually engage these diverse communities who have sometimes multiple identities in thinking about what to do with this data. But we dedicate as a health research community very little resources to engaging with communities relative to other things that we do, and we can do a lot better with that. I want to just tackle one of the questions in the Q&A around the just practical thing about running into the challenge of collecting this data, in this case, like in a busy children's pediatric hospital in the emergency, and just noting that there's a very low amount of time given to, say, the clerical staff. I agree. I think there's not, that's been also something we found with the research we've done. We have an active study going on right now called the Spark Implementation Study, where we are trying to look at what's the best way to provide training and how much time is required by staff to try to do that better. But clearly, we need to have a nuanced approach. We need to have an approach that, for some people, these questions are not an issue. They're very straightforward. Others need a lot more time and need to have the option of, I'd like to talk to someone about these questions, why they're being collected. And we need to do a much better job of actually posters and pamphlets and conveying to patients why the information is being collected, how it can be used to improve your care, but also actually be used to think about who are we missing, where the gaps are. as well. There's another good question about, noting that sometimes these talks are very theoretical. Can you give some examples for a primary care provider and their team? How could they ensure an equity? For example, online booking. Great example. So now many organizations are moving to online platforms for not only booking, but for virtual care and things like that. So a simple, tangible thing would be if you had this information on things like not only race, but also language preference, immigration status, things like income, you could actually see who is accessing those services, who is using online booking, who is booking virtual care visits, who's coming in, and then be able to see, we are systematically missing a whole bunch of people. We know that virtual care kind of exploded during the pandemic, and it just suddenly went from a very minor part of the care we provide to now, in many cases over 50%, and it's really grown tremendously. There is some work that used the data we have available, like things like postal code, to say that it was a fairly fair uptake. But I think many of us are worried that as we increasingly use things like virtual care and virtual booking and other methods, that it's going to leave people behind. People who don't speak English as a first language and are mostly English systems, people who are lower income, who may not have access to technology. My own experience as a practicing family physician in downtown Toronto is that my patients who are dealing with poverty, homelessness, are the ones who are not able to use these platforms. They often can't pay for their cell phone. They often lose contact with it. So I have a lot of worry about the equity gaps that will emerge as we increasingly have a system that really relies on that. So that would be a really tangible way of saying, let's look at who's using these services and do a fairly straightforward analysis by things like these variables. And there's another question about, what about the capacity for this in Northern Ontario? And would people be interested in that? So the good news is actually one of the Poplar networks is based at the Northern Ontario School of Medicine. And we have some really fantastic leads of that network who maybe Marissa could actually put in the chat their names for people. But they are Brianne Wood and Barb Zellick, who are really passionate about using research to improve care and to really work with communities to actually create change that's based on the data and using this type of information to really show progress. So I think you can see there's multiple levels to this where we're talking about, can we transform the way we do research and who's involved with it, who has access to the data, and so on? Can we change the way our health organizations run and who they're serving, and actually really measure the degree of systemic racism or systemic inequities, and then look at ways that hold those organizations to account? And then you can see that part of this is really a lot about building connections to communities who are the ones who are advocating for this change. So it's kind of like saying, in your area, whether it's Northern Ontario or Southern Ontario, Western or East, what is your relationship to the local communities? Could you envision not not just relying on kind of the same community organizations, but actually building new tables? One of our huge strengths in primary care is we serve the whole population. So every day we have patients from diverse communities who are engaging with us and coming in. What are we doing to engage them in these discussions? My thinking has been that it would be useful to create these provincial tables because it just would. There's a lot of similarities, and there's not a need to every single region to create its own table. It would actually be quite a burden, but a fairly large, diverse table that represents different communities could be very useful. Interestingly, our colleagues in Manitoba and in Nova Scotia have done work in this area around what would it look like to engage community organizations and representatives in both the interpretation of this type of data, but also in setting direction. And we can learn from them as well. We can share what we learn as well as we create these structures.
Thank you. There's a couple of questions that have come in the chat, so I'm hoping we have time to quickly address them. Because you talked about the need for political action and political transformation. And do you have any thoughts about how health researchers or practitioners, or in fact leaders, being hesitant to engage in politics and how to address that?
Yeah, and I know we're just coming to the end of time, so I'll try to answer this briefly. It's really important to differentiate between, politics and the partisan kind of discussions and taking one side of a party or another, and the policy process, which we are all involved in as people who have a lot of privilege, a lot of voice. We are actually folks who are able to, write reports, write op-eds that get published, speak to policymakers far more than others. So we shouldn't underestimate our power. I think whenever we do this, we have to do it with communities, not on behalf of communities. So be allies and not speak on behalf of anyone. But then also always stick to the evidence. Like, we actually have the evidence around who is being missed, where the gaps are, and we have a duty to actually speak to that. We now know that, part of being a health researcher is engaging in creating change. Like, we're not doing this just to publish a paper and then move on. We're doing this to actually improve systems. And so political change and engaging in that process is a core, part of our work. It's not a skill that's always taught, but something that we can teach to future generations.
Thank you so much. And this is the end of our time. So once again, we have recorded this, and we'll be sharing that recording along with the slide deck in the next few days. And we'll include links to the Poplar Network and SIPSN for people who are interested in joining or getting involved. So I'd like to thank Andrew for taking the time to make this presentation, sharing his knowledge, the Poplar Network for organizing this series, and everyone who registered and took the time to be here today for this important learning. I wish you all a wonderful rest of the week.